As a woman, were you taught anything about the change of life? In your mind, does going through menopause or even perimenopause mean that you have to be abstinent and sex is no longer a part of your life? Well, we're going to explore all of these myths, and I have a special, amazing guest, a board certified OB-GYN, and she's going to tell us all that we need to know about this important stage of life. Stay tuned. To the secret formula of femininity for women who want to live a more feminine, fun, and fabulous life. I'm Dr. Nicole Montero, your host on this weekly journey to unlocking your inner radiance, nurturing fulfilling relationships, and becoming the best version of yourself. Welcome back, everybody, to this episode of The Secret Formula of Femininity. I'm your guide on this journey to tapping into your feminine essence, Dr. Nicole, and I have an amazing guest today. I've been waiting to dig into this topic. Board certified OB-GYN, expert on women's health, intimacy, menopause, perimenopause, and all that we need to know to be our best as women, Dr. Sadaf. And I am going to read her bio. It's amazing. I'm just going to read a bit of it because I really want us to dig into this conversation. So, as a practicing OB-GYN in New York for over 20 years, Dr. Sadaf's mission has always been to empower and educate women. Most recently, she started a concierge medical practice serving patients in New York, and she has a telehealth practice for those in Michigan. While she assists patients in all aspects of female health, her focus on sexual and menopausal health, as well as intimacy coaching, has really helped so many women. She believes that all women, regardless of their backgrounds, have the potential to live life to its fullest. Thank you so much. I think we are hearing a lot about menopause, perimenopause, intimacy, all of these things, but we need the actual information that is going to empower us. So, welcome, Dr. Sena.
Thank you so much for having me. I really appreciate it.
Yes. So, I always want to get personal, like your accolades speak for themselves, and your full bio will be in the show notes. But I want to know what about this issue? Why OBGYN? What is your story? Why was it important for you to focus on women's health, particularly menopause, perimenopause, and intimacy?
Yeah, so thanks for the opportunity. Basically, as I was growing up, I am of Pakistani descent, and I grew up in a fairly conservative community. And I never really saw too many female role models growing up. There were a few, but not very many. And so I always wanted to be the role model I never had. And I always saw women in the community, but it was almost like they didn't really speak up. They didn't really have a voice. And I wanted things to be different. So I also um, loved women's health because, again, I wanted to empower and educate the women that I saw in the shadows, and I wanted to lift them up. So I really wanted to focus on that in medical school. And so that's how my journey for OBGYN began. And then as I started to get older and my patients were also getting older,
Mm.
I noticed that menopause, perimenopause, sexual health was something that in medical school we really didn't get much of. And then in residency, I didn't get very much of that either. And so I thought that that was something that was really important, and I wanted to fill that void for women. And so I began my own, you know, furthering my own education in a menopause, perimenopause, and sexual health. So I am a Menopause Society certified practitioner as well as an ISWISH fellow. ISWISH stands for the International Society for the Study of Women's Sexual Health,
Mm.
and it is an organization that comprises of different types of healthcare professionals, such as mental health therapists, you have pelvic floor therapists, you have physicians, you have gynecologists, you have urologists, you have all different healthcare specialties in there that focus on sexual health. I also did a year-long course with the University of Michigan on sexual counseling and education, and I did coaching through Rutgers University. So I really felt it was very important to empower women during this time that can be super confusing for a lot of women because one, their practitioners may not know that much about perimenopause, menopause, and sexual health. And two, because the more knowledge we have, the more agency we have over our own bodies, and we can also then advocate for ourselves. And so that's why I thought it was so important.
I'm so glad that you listed not just why you got into this, but all of the training that you took it upon yourself to get. Because I think people don't always understand what it takes to truly understand something as great as women's health, like such a broad topic, but to understand so many aspects of it so you can really help women. Um,
Yeah,
yeah,
absolutely.
so why it's interesting that you said in your education you had to seek out all of this knowledge. Why do you think menopause, perimenopause, and women's health at this stage are still either taboo or just ignored, neglected, even in 2025?
Yeah, I mean, I don't think they're taboo as much as they just are not a priority. You know, in medical school, we're learning about everything of the human body, and they just didn't. Definitely, I mean, you know, I went to medical school a long time ago, so definitely during my training, you know, these things were not in the forefront and they were not of as big of a concern. I mean, sexual health, you know, we learn the physiology, but you really don't learn anything else outside of that. You don't really learn too much about relationships or anything like that, about mindset. And then in residency, we definitely don't. I mean, even as recent as 2021, I was part of a residency program, and I know for a fact they did not focus on menopause, perimenopause, and sexual health at that time. Now, if things have changed, I'm not sure. I am. I do lecture to medical students now in one of the medical schools in New York, and I lecture to them on sexual health, specifically female sexual dysfunction, and I also lecture to them about menopause. So I can say that some of the schools, well, at least this one school, is getting lectures on those very important topics, but most of our training did not focus on that. And when I was a resident back in the year 2000 through 2004, we did not, you know, in 2002 is when the WHI study came out. And it was because of that study that women were told to throw away their, you know, estrogen, and it was bad and it caused breast cancer and stuff. And so that dogma has stayed with the medical community up until now. Even a lot of physicians still don't feel comfortable prescribing medications such as hormones to women because they're not really sure, one, how to prescribe it, two, whether or not they should be fearful of causing breast cancer, which we know that estrogen does not cause breast cancer. But so, you know, there's just a lot of education that needs to be done. And unless the physician is going to go and get extra education and knowledge about these specific topics, they're not going to feel comfortable and they're definitely not going to prescribe.
Yeah, yeah. Now, I want you to go back. I was going to ask you about some common misconceptions, but you brought up the dogma that still exists about hormone replacement treatments and estrogen. Could you just tell us a little bit about that study, what was wrong, and what women need to know now?
So the WHI study was a study that was a randomized placebo controlled clinical trial that was supposed to examine the effects of estrogen plus progestin on various health benefits. So it was actually it was funded by the National Heart, Lung, and Blood Institute and the NIH. And basically, the trial was designed to last for 8.5 years, but was stopped after 5.2 years by the National Heart, Lung, and Blood Institute because they said the risks of women getting breast cancer were increased, and then the health risks of hormone treatment, the risks were greater than the benefits, and that's why they told women to just come off of these hormones. So before 2002, women were taking hormones, and you know
For
we were
menopause.
for menopause,
Uh-huh.
yes, for
Uh-huh.
menopause, and even some during perimenopause, because we know
Okay.
that women have hot flashes and night sweats are vasomotor symptoms. But the treatment for that is estrogen. The reason why we get those hot flashes is because the estrogen is going down in our body, and that's why we get those symptoms. And so before that, women were getting estrogen and progesterone for these symptoms. But then after that study, because the study said that the risks were greater than the benefits for being on hormones, a lot of physicians were told to stop prescribing hormones. Women were told to throw away their hormones overnight, that they were bad, they were going to cause blood clots, they were going to
Uh-huh.
cause death, those things. And so that's why that idea that hormones caused breast cancer, that's why it has stayed with so many physicians, because that's what we were taught. And so when you go back now and you look at additional papers, to look at whether or not this was the case, they don't actually uh, say the data does not support what they had said at that time. So
Mhm.
the problem with the WHI study was that it failed to acknowledge reporting of non-significant results. It used nominal rates as primary statistic, and it didn't adjust for factors that may have created like a false positive result. So what they stated then was that, oh, we took women off of hormones, and because we took them off of hormones, there was a decrease in breast cancer incidence in the US following
Mhm.
the decline of hormone use, and that was not correct. Also, the WHI study was done on women that were 12 to 15 years into menopause, and women were without their premenopausal levels of estrogen and progesterone long enough to bring about changes in various bodily functions, such as increasing the risk of cardiovascular disease, increasing the risk of osteoporosis. And we know that the longer a person goes without hormones, the higher the likelihood that other diseases will
Oh,
uh, start to develop. So, for example, somebody that was never had anxiety and depression can develop anxiety and depression during perimenopause, menopause. Somebody that was never diabetic may become pre-diabetic because of the increased insulin resistance due to the fall in estrogen. Somebody that didn't have hypertension, high blood pressure, could develop hypertension after menopause, because we know that estrogen is anti-inflammatory and it allows for relaxation of the blood vessels. And so when
mhm.
you no longer have the estrogen, it makes our blood vessels stiffer, which can result in high blood pressure. So there's a lot of things that
Estrogen
estrogen,
is important for it, sounds like.
yes, that is correct.
Yeah.
And now the WHI people, so the authors, the most recent claims that we know about the WHI is that now we know, which we knew, and there were actually other researchers that then went back and reevaluated the data of the WHI and said that, no, these claims are false. So now what they're saying is that hormone therapy is actually the most effective treatment for managing vasomotor symptoms, which are those hot flashes, the night sweats, all of those things. That estrogen alone decreased breast cancer risk by 23% while reducing the breast cancer death rate by 40%. And estrogen alone is associated with a decreased risk of breast cancer, decreased risk of death from breast cancer, and decreased risk of death from overall causes. The most benefits that we see are within 10 years. So if somebody, when they go through menopause, if they decide that they want to do hormones, the most benefit that research has seen is for those women that start within 10 years of menopause or less than the age of 60. And the thought is that those chronic diseases have not developed already at that time. And so these women will benefit the most from hormones.
Okay.
Um,
It sounds like it sounds like there were a lot of confounding factors in the original study and it didn't allow for accurate data. And now you're saying there's a lot of evidence to the contrary that estrogen and hormone treatment is really helpful for women within a certain time period and actually reduces breast cancer risk.
Yes, yes. And actually now, so that timing hypothesis that they stated, some researchers and physicians are looking into that and saying that, is it really the case? Can women actually that are in their 60s, can they still take estrogen? Or is it that they have to be less than the age of
Mhm.
16 within 10 years of menopause, right? So they're looking at that timing hypothesis and saying, can something be done about this? Can women even up until the age of 65, can they take hormones even if they never took hormones before? So that is definitely a nuanced conversation that needs to happen with your physician. And I
Yeah.
would never state that, everyone is a candidate, because everyone may not be a candidate for
Hmm.
hormone. if you are a candidate for hormones, that might be something that you consider. So, also what we have to understand is with that study, we at that time we were using a different form of estrogen and a different form of progesterone, and now we use something that's more bioidentical to our own body, and we also use a patch. At that time, they were using oral pills, which we know
Okay.
carry slightly increased risk of, like, say, blood clot and things like that. Whereas if you do use medication that is through the skin, whether it is a patch or a gel, or if it's a spray, that we know that those tend to carry less risk in terms of side effects for estrogen as opposed to those that are taken oral.
Well, we got deep into the weeds right in the beginning, and I want to back up a little bit and ask you to let women know what are some of the signs of perimenopause? What is the difference between perimenopause and menopause, and how can they tell that they're, first of all, transitioning into perimenopause and then into menopause?
Yeah, absolutely. So perimenopause, so menopause is literally like a year and a day. So what that means is that menopause is when you go a whole year without a period, right? When you've gone a whole year without a period, that's menopause. All the time after that is considered postmenopause until basically a woman dies. So that's she's in postmenopause.
Okay.
The time before menopause is considered perimenopause, where the periods can be irregular. That can be one of the first symptoms and signs. Perimenopause is irregular menses, basically those menses that either they can be really frequent or they can be spaced apart. And as your periods get further and further apart, so, sometimes you'll have a period and then you won't have another period for 2 months or 3 months, whatever. When it goes a whole year without a period, then you're in menopause. But yeah, slowly those periods start to space further and further apart. That's perimenopause also. But what about for those women that have had a hysterectomy, right? How can they tell
Yeah.
that? But if they still have their ovaries,
Uh-huh.
right? If they still have their ovaries, then they will still experience those symptoms of hot flashes and night sweats, and mood changes and things like that. But not all women experience hot flashes and night sweats. Some of the other symptoms that can come about with perimenopause, you can have a brain fog, you can have heart palpitations, you can have joint pain, you can have, there's so many things. You can have weight gain, you can have dry eyes, dry mouth, you can have a whole bunch of symptoms. You can have something called genitourinary syndrome of
Mm.
menopause, which is where basically you get a lot of vaginal dryness, itching, burning, irritation. Um, Women can experience pain with intercourse. They can experience decreased lubrication. They can experience decreased or delayed orgasm, pain with sex. A lot of things. You can have recurrent UTIs. You can have overactive bladder. So there are tons of things that can happen in perimenopause. The important thing is that if you are having like a whole constellation of symptoms, really important to go see your healthcare provider and see whether or not you are in perimenopause, because maybe you are. The mean age for somebody to, so let's talk a little bit about the age range. So
Yeah.
the mean age for somebody to go through menopause is around 51, 52 here in the US.
Okay.
For the time, what's really interesting actually is that in 1994 there was a study that was begun. It's called the SWAN study, and basically what that was is it was a study that looked at women through midlife, their biological changes, what happens to them, their psychological changes, all these things, and they looked at it based on ethnicity. And what they found is that different ethnicities will go through perimenopause for different lengths of time. Remember, perimenopause is a time right before menopause, and for a Caucasian woman in the US, she will go through perimenopause around 7 years before actually menopause. Okay, that's a long time.
The stretch
But
of get possibly having those symptoms
uh,
and transitioning. Uh-huh.
correct, correct. But what's even more interesting is that different ethnicities, right? So here we learn about African American women, and they will actually go through perimenopause for 10 years. 10
Okay.
years. Imagine going through with like cognitive changes, right? So a lot of people will experience brain fog, sleep disturbances, mood changes, increased bone loss, all of those things, right? For African American women can be happening 10 years before. So imagine if the mean age for somebody to go through menopause is 51, 52. African American women can be starting as early as 41, right?
Mm. So
And
yeah, 40s. Uh-huh.
right, exactly. And menopause can actually, I would say that I would go and ask your mom if your mother's still alive, or
Mm-hmm.
um, at what age she went through menopause, because that'll probably be around the time that you go through menopause, right?
Uh-huh.
So what if your mom went through menopause at like 48? Well, then, you could be starting perimenopause at the age of 38, right? So this is why these things are really important to know, because then you can advocate for yourself and you can
Mm-hmm.
go and talk to your doctor and tell them that, hey, listen, I'm having brain fog, or I'm having this, joint pain, or these heart palpitations, all these things that are starting to happen. And if you don't get the answer that you're looking for, or if your doctor doesn't realize that perhaps you may have perimenopause, or you may be in perimenopause, then maybe it's time to find another doctor, right? That will listen to you, that won't dismiss you, or that won't think that you're too young. A lot of times I've had patients in my clinic where the doctors, I have a 44-year-old Hispanic female, and so Hispanic women will go through perimenopause for 8.9 years.
Okay.
And, Southeast Asian women can go through menopause even as early as 46, 47.
Okay.
So,
And so perimenopause could be in their 30s if they're going through menopause in their mid 40s. Uh-huh.
right, right, right. So
Yeah.
if you're going through menopause, right, if you go through menopause, which is a whole year without a period in your 40s, right, you could have begun perimenopause in your 30s. That is
Mm-hmm.
correct.
Mm-hmm.
Sometimes we see that some women will begin it as early as like 35, 36
Mm-hmm.
perimenopause. So it's crazy. And that's why, it's really important for physicians to know that this is happening so that they can let their patients know, because, um, I'm sure your viewers have heard of Naomi Watts, who's this famous British actress, right?
Mm-hmm.
So
Mm-hmm.
she wrote a book called Dare I Say It, and she talks about her own perimenopause, menopause experience. But her point is that, at the age of 36, she's now ready to have a child, but she doesn't realize that she's already in perimenopause.
And how
And
does that affect her fertility?
well, exactly. So remember, in perimenopause, you are, even as we age, our
Yeah.
eggs become less and less, right? We have less eggs in our ovaries. And so you are really going to, because if you're thinking of menopause as a time where you no longer have a period, that means you're no longer ovulating, which means that you could not have a biological child of your own if you're not ovulating, right? Sure, you could get like a donor egg
Uh-huh.
and try and have an embryo implanted, and you'd need to be on a whole bunch of hormones because your ovaries have shut down, they're not working. So you'd need like, outside hormones. And I'm not an infertility specialist, so I don't even know how that would work out, but I'm sure they've devised something. However, my point is that if you are going through perimenopause, then your chances of getting pregnant, right? Because you're not ovulating all the time. You also have to take a look at the quality of your eggs, all of those things. You would need to be evaluated by an infertility specialist, where they would take a look at the quality of your eggs. They would do blood levels for something called AMH, which is anti-Mullerian hormone. They would do that. They would check your estradiol. They would check your hormones called FSH, LH, because
Mm-hmm.
that would tell you, one, the quality of your eggs by doing that AMH hormone. Two, it would tell you if you're already on this, say that your hormone levels are already high, your FSH, LH, that could mean that it would be really, much more difficult for you to get pregnant, because it's telling you that your ovaries are starting to
Are
shut
starting
down.
to cut down. Okay.
Okay.
Interesting. So there's the fertility part, there's the lead up to menopause with perimenopause, there's the symptoms. It sounds like such a complex kind of machine. It just makes me think how complex we are as women.
Yeah.
And so much of probably what happens is women are disregarded. Like people are like, oh, like you said, you're too young, or don't worry about that, or they just don't know enough to help advise women.
Yeah, I mean, I think that a lot of times, what can happen is that women are dismissed, right? So come and they'll talk about what their symptoms, and if a physician doesn't know that, the different women based on their ethnicities will go through perimenopause for different lengths of time, then I think that we may miss out on, especially if a woman is trying to get pregnant, right? So
Mm-hmm.
if she's starting perimenopause in her late 30s, and this is the time when she found somebody and is trying to have a baby. I mean, really, time is of the essence. In fact, I just was talking to somebody the other day, and she said, "Oh, I want to have another child, but I think I'm too old." And I literally just met her, so I didn't want to get into all the
Yeah.
details. But,
Yeah.
I told her, if you think that you are too old or if you're worried about that, then I would say that you go and see an infertility specialist, because with infertility, it's all about time.
Mm.
And
You
you
don't
really,
want to waste time. Uh-huh.
yeah, you don't want to go like years thinking
Okay.
like, "Oh, I wanted to have this baby and I just haven't moved on it." You have to go and seek help right away, because the younger your eggs are, the higher probability that you may be able to, I don't want to guarantee anything for anyone, but you may be able to have a child, right? As we get older, our eggs get older. As our eggs get older, there's a higher likelihood of chromosomal abnormalities, a higher
Mm.
risk of miscarriage, a higher risk for Down syndrome. So there is time in the world of fertility,
Mm-hmm.
time is the essence. You got to move.
Yeah, yeah. I think that's such an important message to hear because the way you're stating it, there's no judgment. It's just a fact. Like you
Yeah.
have to look at the timing of all of this.
Yeah. Yeah.
Mhm, mhm. Yeah. So how does perimenopause and these changes we go through as women affect our libido and
Oh,
our sexual, not just health, but like our sex life?
yeah. I mean, that's such a that's a very loaded question. So, there's so many things with libido. Libido is, a friend of mine calls it a mood. I
Hmm.
would say that libido is the desire, right? The
Hmm.
desire to have sex and or to be intimate with somebody. And libido, gosh, so I'll tell you this. There was a study that was done. I can't recall what year it was, but anyways, it's called the Preside study, and it was a study that looked at they surveyed women, and it was over 31,000 women, and what they did is they were asking them about if they experienced any type of distress regarding their sexual function.
Uh-huh.
And so what they noted was that women, and I'm going to actually pull up this study now too, because you're having me pull up all my studies today.
And I love it because I think people need to know what the evidence is. It's not just pulling it out of a
Yeah,
hat. Like you are looking at the evidence.
yeah, yeah. So here, let me tell you a little bit about this study. I'll tell you exactly about it. So it is called The Prevalence of Female Sexual Problems Associated with Distress and Determinants of treatment seeking. Okay, it's called a Preside study. And it was a cross-sectional, nationally represented mailed survey of US adult women. The respondents were 31,581. And the response rate to this survey was about 63%. It was a 42 item questionnaire that measured sexual function, sexual distress, demographic, and health related factors. And what they noted was that women, that this distress of sexual dysfunction came about in midlife, more in midlife than in any other time. Um, and that the prevalence of distressing sexual problems, like I said, peaked in middle age and was considerably lower than the prevalence of sexual problems. So basically, what we have is that around the age of midlife, so between like I would say like 40 to like 65, that's the peak time that women experience sexual distress. Okay.
Hmm.
The number one thing that causes women the most amount of distress, what do you think that is?
I would say their perceived loss of libido.
Yes, it is desire.
Uh-huh.
Their desire, when you have so the number one sexual problem that came about, so it was either, any type of sexual dysfunction or orgasm, arousal, or desire. And of the desire, arousal, orgasm, the number one distressing problem was desire. It was
Yeah.
about 38%, and about 10% of women described that they had distress with it. So when we talk about, there's something called hypoactive sexual desire disorder, and it is basically low libido. that causes distress. It happens, it's been going on for more than 6 months. It's not, you're not able to resolve it. And it's causing you a lot of distress. So that's called hypoactive sexual desire disorder. And for that, we have only three medications. And, for men that have erectile dysfunction, there's like, I don't know, like 85 medications.
Cialis, and Viagra, and
Yeah, right,
all the other.
exactly. All of those, right? So for women, for desire disorder, what we have is we have two FDA approved medications, one that was approved in 2015, another one that was approved in 2019, and testosterone, which is non FDA approved, but is used, and it is there. It was a consensus statement that was released in 2019 that stated the use of testosterone in women for hypoactive sexual desire disorder. But it's really important to know that, one, there is medication, there is, but the thing with libido, let me tell you, is that it is
So
multifactorial.
psychological as well.
Correct. It is multifactorial. It is
Yeah.
not just that, we need more dopamine in our brain, which is what
Hmm.
a lot of these medications they help to do, but there are so many things that affect desire, right? So for anyone that comes to me in my office that wants to talk about desire, I tell them this is like like a 2-day conversation. I mean,
Yeah,
we get
it's
started.
not a 15-minute chat,
No,
right?
it's not a 15-minute chat. It
Yeah.
is, so you have to talk about, one, let's just really quickly go over what are things that I would look at. So for somebody, so we know that, okay, when we talk about female sexual dysfunction, the number one thing that bothers women, causes distress, is their desire.
Mm-hmm.
And so when we talk about desire, we have to look at what we call the biopsychosocial model in sexual medicine. And you have to look at things that are biological that could be causing a decrease in desire. For example, SSRIs, right? Antidepressants can decrease desire. They can also cause a problem with orgasm.
Mm-hmm.
We know that birth control pills also can decrease desire by decreasing testosterone, and birth control pills can also cause pain with sex. So, so there's biological, right? So we have to look at medications that a patient is taking. What medications are they taking that could be affecting their desire? Then we have to look at anatomical reasons, right? There could be that the patient is having pain
Dryness, right? Mm-hmm.
every time that they have intercourse. So are they having any pain? Are there any hormonal issues? Also, we notice that in midlife, because our hormones are going down, the estrogen is going down, progesterone, even testosterone is going down, that our whole vulvar area is hormonally sensitive. And
Mm-hmm.
so when our hormones go down, we can have that tissue can start to become thinner, it can lose color, it can there's so many things. It can lose its elasticity, so it can cause pain with intercourse.
Mm-hmm.
Uh, there can be pain with entry. There can be tight pelvic floor muscles. So there is so many things that can cause decreased libido, and that's just the biological component. And that
Yeah.
so that's just a little portion of the biological component. Then we have the psychological component, right? So if women are developing new onset anxiety and depression in midlife because the estrogen is going down, and the receptors in the brain are like seeking out estrogen, but there's no estrogen there,
Mm-hmm.
and that anxiety and depression is also going to affect their mood to want sex, right? And so that's going to be a component. Then we go to social components. So if we look at, was this person raised in a sex negative environment that is affecting how they feel about sex? Do they feel that sex is wrong, dirty, shameful, and they're just not interested in it because they have all the sex negativity that they grew up with? Is it that they have so many kids or so many things going on in their life? Are there a single mom that is working multiple jobs that is then having to come home and take care of children? And then all of a sudden now sex is just another chore on top of
Sure.
her
Yeah.
list of things to
And
do.
the thing that I had when I'm listening to you, I'm thinking about also societally the messages that women get, which is that their desirability goes down. And I know for a fact that like your perception of how desirable you are has an impact on your desire to even have sex. And so we get all of these mixed messages. Like you hear 30-year-old women saying, I'm old, I'm unattractive. And I'm like, whoa, by the time you hit 50, you've got to work on how you see yourself. But it can be hard with all of these negative messages.
Correct. So body image is a huge problem for women. And, a lot of times women will, when they're being intimate with their partner, will be doing what's called spectatoring. So they'll be looking at themselves from up above
Uh-huh.
and not really in their body. So not really being in the moment. And so that will also decrease desire because you're not really focused on what it is that you're doing, but instead you're just judging yourself, right? So if
Mhm.
we're constantly critiquing ourselves and judging ourselves, that's not going to make us happy. And that's definitely not going to make us want sex. We have to see that, when you are in this relationship with this person, are you being satisfied? Are you able to talk about what your needs are? Is there communication there? Because if there isn't, you're not really going to want it. You're just going to
Yeah.
be like
It's a
vessel.
chore. Yeah.
This and so many other things can affect your libido. So it isn't just one thing. So it's not just like, I'm going to take this medication, all of a sudden now I'm going to
Mm.
have libido. It's going to be okay. You take this medication if you find that if everything else comes out negative, and maybe this medication will help. But maybe you'll need to take this medication. Maybe you'll need to go for sex therapy, right? Maybe you'll need to go for therapy. Maybe you'll need to work on how you see yourself. Maybe you'll need to work on the sex negativity that you have. Maybe you'll need to change your medications. Maybe you'll need to change your antidepressant so that it's not an SSRI, but that maybe you go on Wellbutrin or something else that's not going to affect your libido. But it's just important to know that it's normal for women's libido to go down, but how do you promote that libido and how do you make it go up if that's something that you want?
Yeah. I'm so glad you said that because I wanted you to touch on before we end. What are some practical things that women, if they hear all of this, they recognize some of the symptoms, they recognize changes in their libido, how they view themselves, what's going on with their bodies, and they're not getting, they can talk to their healthcare provider, but what are some things that they should do, whether it's to feel better about this process, to start researching, like what are practical things that they should start doing as they approach this stage in life?
Yeah, absolutely. So there are a lot of things you can do. You can definitely listen to podcasts like this
Mhm.
one, or I have a podcast called the Muslim Sex Podcast that I talk a lot
Mhm.
about coaching. I talk about libido. I talk about arousal. So find podcasts that you can listen to that will help you with whatever it is you're going, whatever else it is that's going on in your life. I have one on menopause. I have one on, menopause 101. So
Uh-huh.
I think those are helpful. So books. So I would say like podcasts,
Uh-huh.
books would be the other thing. I'm in the process of writing a book. And so hopefully that'll come out later on this year. But it's going to be talking about coaching and how to move forward in your relationship. Also, I would do a journal, like I would start journaling and I would start journaling your symptoms. I would start writing about, because in this podcast, we talked a little bit about perimenopause. We talked about menopause. We talked about the WHI study. Then we talked a little bit about libido. And so, for any of these things, right? If you're a woman in midlife and you're experiencing these things, and even if you're not in midlife, whatever
Uh-huh.
age you are, and you're having these symptoms and you're not really feeling like yourself, I would start journaling your symptoms, maybe writing down how it is that you feel. I would also, one easy thing that you can do with your partner is start to
Mhm.
communicate. Communicate to them what it
Yeah.
is that you want, communicate your desires, what it is, whether or not you're being satisfied in the bedroom,
Mhm.
make time to have those important conversations. We make conversation about, finances and about, what's going on in the house with the kids.
Day-to-day things.
Sexual health is part of a person's overall health. I would
Mhm.
say like sexual health is a barometer of a relationship, right?
Mm. Mhm.
So whatever's going on in the bedroom is also going on outside of the bedroom. So if we're not communicating, if we're not talking about things that are important to us, then we're definitely not talking about things going on in the bedroom. And so I would say that, and research has proven that the number one factor for female sexual satisfaction, is communication. To then be able to advocate for yourself, maybe follow people on social media that are talking about these things, to that way that can give you an idea of how you can approach that conversation.
Mhm.
And then, finding a healthcare provider that is able to spend that time with you so that you can have these discussions and you can figure out, if you're having decreased libido and it's causing you distress, what are the things that you can do and what are some simple things that can help you move your relationship forward.
Wow, Dr. Sadaf, listening to this last part, I feel so hopeful, because I
Yes.
think it can be, I talk to women and it can feel daunting. It's like sometimes information overload. But I
Yeah.
think the way you laid out, like the things that will empower us as women, and so much of what I talk about on this podcast is communication. I feel it's one of the most empowering things, and we have the power to shift our relationship through our communication.
Yes.
So just hearing the medical side of it, that all of the research and the studies talk about, as you said, that communication can really empower you in your relationship, regardless of perimenopause. Because also, what I'm hearing from you is the more we understand this and understand it's just part of our lives as women, we don't have to fear it. We don't have to, banish it or think it's something bad. We were created to go through these different stages, and it's beautiful. Like, I love the research that you're doing on this.
Yeah, yeah, and honestly, the way that I see perimenopause, menopause is that it really is a privilege for
Hmm.
us to be able to get older because so
Mm,
many women throughout the world do not have that
yeah.
opportunity. And not only do we have the privilege of getting older, we have the privilege of knowledge here and access to medications if we desire to go on them, which a lot of people throughout the world do not have access to meds that can help them in midlife and beyond, and so they suffer with either painful sex or there's hot flashes or osteoporosis and so many other things. We are just so fortunate to be here living in the time that we are and have access to all this medication and science and research that we should really access it to help live that fulfilling life in the future.
Thank you so much. Speaking of privilege, it has been a privilege to have you here and to learn. And I hope that the audience has taken away what I have as well. Where can people find you if they want to follow you and see more about your work?
Yeah, thank you for the opportunity. So, I am on social media. I'm on Instagram and TikTok at Dr. Sadaf OB-GYN. I have a podcast called the Muslim Sex Podcast. It's not just for Muslims, it's for
Yeah.
anyone that wants more
Hmm.
knowledge. It's just the name of the podcast. I also have a website called FemV Health. That's the name of my private practice. I'd love to have some more patients. If you want to come and be a patient of mine, I'm accepting new patients. So it's called femvhealth.com.
Okay.
Also, I host a retreat for
Mhm.
midlife women focused on perimenopause, menopause, sexual health. And we do sex coaching and also nutrition. So I have a colleague of mine that was a nutritionist before she became a physician, and she hosts the nutrition aspect of it. And we go to Morocco for a week. It's just
Beautiful.
amazing. Oh
I
my
might
God,
have
Morocco!
to sign up for that. Yeah.
Morocco is amazing.
Yes. I've been
Such
to
a
Casablanca, so I would love to go back. Yeah.
Yeah, we go to Marrakesh
Uh,
and we also go to Essaouira, which is on
oh,
the
wow.
coast,
Uh-huh.
which is just amazing, really amazing. So you can follow me on social
And
media.
we'll
You
put
can,
all of the links in the show notes for people to click. Thank you so much. And this aligns so well with the work that I do to help women in their relationships. Also, in the show notes will be a link to my book, The Boundaries to Bliss Blueprint for Women Who Are Finally Ready to Win at Love. And of course, my coaching community, the Boundaries to Bliss Society. I truly believe that boundaries and communication, self love, and tapping into our femininity are our superpowers as women. So, thank you so much for joining this episode, and we will see you next time.